Hello everyone, welcome back. In the last session, we discussed about the physiology of thyroid hormones and the approach to thyroid function testing. So today we'll start off with the diseases of the thyroid gland. So we'll start off with hypothyroidism. So let us look at the etiology of hypothyroidism. So hypothyroidism can be classified as primary and secondary. Primary hypothyroidism is basically a disorder of thyroid gland per se. Secondary hypothyroidism basically occurs due to disorders which affect the pituitary. Okay, so pituitary or central hypothyroidism is your secondary hypothyroid. So let us look at primary hypothyroidism. The most common cause of primary hypothyroidism is your Hashimotos thyroiditis. Hashimotos thyroiditis is nothing but your autoimmune thyroiditis. In the olden days, it was iodine deficiency, but now it is your Hashimoto. Then iatrogenic causes. Iatrogenic causes include following surgery or following iodine 131 treatment, which is used in the management of Graves' disease or radiation or cancers. Drugs which can cause hypothyroidism includes iodine excess, including iodine containing contrast media and amiodarone. Apart from that, some kinds of tyrosine kinase inhibitor. Checkpoint inhibitors like ipilimumab, rivolumab, pembrolizumab, all of these can also cause hypothyroidism. Okay, so we have learned Hashimoto, we have learned drugs. Now, congenital hypothyroidism can be because of agenesis or dysgenesis of the thyroid gland. Then there can be dyshormonogenesis, where any of the steps of thyroid hormone function itself is lost. Then it can be due to TSH receptor mutation. Iodine deficiency we have already seen. Then infiltrative disorders. There can be infiltrative disorders like sarcoidosis, hemochromatosis, which can infiltrate in the thyroid gland. Similar to how they can infiltrate in the pituitary and cause hypopituitarism, they can cause hypothyroidism as well. So amyloidosis, sarcoidosis, hemochromatosis, scleroderma. Then overexpression of type 3 deiodinase in hemangioma, it causes consumptive hypothyroidism. Okay, so this is about the various etiologies for primary hypothyroidism. So iodine deficiency, Hashimoto, infiltrative disorders, drugs, cancers. Then we have your congenital hypothyroidism. Then transient hypothyroidism can be seen with multiple infections which basically cause inflammation of the thyroid gland. This is what we call as thyroiditis. So this can include subacute thyroiditis, or it can happen even after iodine 131 treatment. Secondary hypothyroidism. Secondary hypothyroidism is nothing but your central hypothyroidism. Secondary hypothyroidism is nothing but your central hypothyroidism where the pituitary is involved. So any disorder which causes hypopituitarism can cause secondary hypothyroidism. Fine. So this we have gone through in our disorders of pituitary as well. Fine. Now let us look at the most important types of hypothyroidism. First, we will be starting off with your congenital hypothyroidism. So the most common cause of congenital hypothyroidism is your thyroid gland dysgenesis. So there is a thyroid gland dysgenesis where thyroid gland itself is not formed properly. Okay. Then many a times there can be transient hypothyroidism, mainly because of maternal antibodies. There can be transient hypothyroidism because of maternal antibodies that block the fetal TSH secretion. Okay, so this can be transient. What are the clinical features of congenital hypothyroidism? The child is going to have prolonged jaundice, hypotonia, enlarged tongue, umbilical hernia, right? Over a long course of time, congenital hypothyroidism can also result in mental retardation, and what we call that as cretinism. Okay, so there can be prolonged jaundice, hypotonia, enlarged lung, umbilical hernia, and finally it can result in cretinism as well. How do you diagnose? So T4 levels are checked in the heel prick smears. Treatment basically involves replacement with your thyroid hormones. Early detection and early treatment is very, very important in your congenital hypothyroidism. The next type of hypothyroidism that we should be aware of is the most common cause of hypothyroidism, which is your Hashimoto's thyroiditis. Hashimoto's thyroiditis is basically a type of autoimmune cause for hypothyroidism. So this is an autoimmune disorder. So what is the prevalence? It is about 4 in 1000 women and 1 in 1000 men. So let us understand the pathogenesis of how Hashimoto's thyroiditis happens. So in the thyroid gland, and due to unknown triggers, sometimes certain genetic factors, there can be diffuse inflammation. There can be diffuse inflammation and destruction of the follicles. There can be diffuse inflammation, destruction of the follicles. As you can see here, this is all your inflammatory exudates, and the follicles are also getting destroyed. And these inflammatory exudates can even form these kind of lymphocyte aggregates. So there is lymphocyte aggregates within the thyroid gland. Over the course of time, there can be fibrosis, which is your fibrin stance, and there can be complete destruction of the gland. There can be complete destruction of the gland, finally resulting in a permanent hypothyroidism. Okay, so this is about your pathogenesis of your Hashimoto's thyroiditis. So what are the genetic features, genetic associations? HLA-DR3, 4, 5 and CTLA-4 are your genetic associations of Hashimoto's thyroiditis. Very importantly, lot of other autoimmune conditions are associated with Hashimoto, like type 1 DM, Addison's disease and pernicious anemia, vitiligo. So presence of Hashimoto's thyroiditis can be associated with other autoimmune conditions, type 1 DM, pernicious anemia and vitiligo. Environmental risk factors for the development of Hashimoto's include a high iodine diet, low selenium diet, decreased exposure to microorganisms and smoking. Okay, so this is about the basics of Hashimoto's thyroiditis. Now, how do you diagnose? So the major type of antibodies that you have in Hashimoto's is your anti-TPO and anti-thyroglobulin antibodies. So these are the antibodies which are basically responsible for your autoimmune destruction of the gland. The anti-TPO, the anti-thyroglobulin. 20% can also have a TSH receptor antibody, which is your TRAB. So they can have your TSH receptor antibody, which is seen in your Graves' disease as well. So this can be seen in 20% of the cases, and here it is not a TSH activating, this is a inhibiting antibody. This is a inhibiting antibody. Okay. Now let us look at the different clinical features. These clinical features are arranged in order of their prevalence. So what are the most important symptoms? We know that the thyroid gland is involved in a lot of your basal metabolic functions. So deficiency of thyroid gland or deficiency of your thyroid hormones can result in tiredness. It can result in fatigue and tiredness. Apart from that, you can have dry skin, feeling cold, hair loss and poor concentration. Dry skin, feeling cold, hair loss, poor concentration. You can have constipation. Basically, whenever there is a thyroid deficiency, there is lot of excessive accumulation of glycosaminoglycans. And there is lot of water retention as well, and hence you can have weight gain. There is accumulation of fluid in the lungs, there can be pleural effusions, and there can be gags which are deposited on the vocal cord. Your glycosaminoglycans can be deposited on the vocal cord. So these pleural effusions can result in dyspnea, and the deposition of your glycosaminoglycans in the vocal cord can result in hoarseness of voice. Fine. Then, as far as the menstrual cycle is concerned, hypothyroidism is associated with menorrhagia. Hypothyroidism can be associated with some type of paresthesia as well. Okay. So this is about the symptoms. Now let us look at the signs. Dry skin, puffy extremities, very common because of lot of water retention. There can be puffy extremities. Okay. Then alopecia. Then thyroid hormone is basically responsible for the normal contractility of the heart. It affects the normal contractility of the heart. So if there is hypothyroidism, the heart rate decreases and there is bradycardia, right? Apart from that, there is a delay in the deep tendon reflexes. That means that whenever you strike the hammer, let's say on your knee jerk, in a patient with hypothyroidism, there is a delay in the deep tendon reflexes. The muscles fail to relax and you can have a hung up reflex. You can have a hung up reflex, hung up knee jerk. Okay, so there is a delayed deep tendon reflex because the muscles relax slowly. Then, because of the accumulation of your glycosaminoglycans, There can be accumulation beneath the carpal tunnel as well, causing median nerve compression and carpal tunnel syndrome. Then you can have evidence of various serous cavity effusions as well. Okay, so the classical patient of hypothyroidism, when he presents to you, how do you identify? So a patient with fatigue, poor concentration abilities, he is looking slightly puffy, he is having bradycardia on his pulse, and if you auscultate him, you may have a little bit of effusions here and there, and he is feeling cold, he is having alopecia, constipation. Very, very important. Never forget to check your TSH. So these are all the various symptoms and signs of hypothyroidism. Now what is this Hashimoto's encephalopathy? So this is a relatively rare disorder where there is cognitive dysfunction and sometimes you can have even seizures, mainly because of your Hashimoto's thyroiditis. So there will be elevated TSH levels in more than hundreds. Okay. So this is what we call as Hashimoto's encephalopathy, and the EEG basically shows a slow wave pattern. This is a rare form of encephalopathy called Hashimoto's encephalopathy. Now let us look at how do you approach hypothyroidism and what tests you would like to do. So the first step would be obviously for checking for a TSH levels. If the TSH levels are elevated, then you are definitely looking at what type of hypothyroidism. It is a primary. Because of the feedback, it is going to be a primary. Then if the FT4 levels are normal, so TSH is elevated but the FT4 levels are normal, then you see for the anti-TPO. What is this? TSH levels elevated. TSH levels elevated, FT4 normal means subclinical, correct? Subclinical hypo. Then you go ahead and look for your anti-TPO antibodies. Okay, you look for your anti-TPO antibodies because this is the most common, most prevalent type of hypothyroidism. If your anti-TPO antibodies are positive, then even if it is a subclinical hypothyroidism, you have to treat. Because most of your Hashimoto's thyroiditis happens in the younger age group, and even if it is a subclinical hypothyroidism, you have to treat them because there is an increased risk of cardiovascular morbidities in the later age groups if your thyroid is not controlled in the early stages. If your anti-TPO is negative, then you do not treat. Okay. How do you treat? That we will be coming to. Now the TSH is elevated and the FT4 is low. That means that this is a full-blown primary hypothyroid. Okay, anti-TPO positive, it is Hashimoto. You treat them. If anti-TPO is negative, you look for other causes. Maybe iodine deficiency, maybe certain thyroiditis, and so on and so forth. If your TSH is low and you are suspecting a pituitary disease, then go ahead and do an FT4. When will you suspect a pituitary disease? If he is showing evidence of other hormone deficiencies, if he is telling headache, visual field defects, etc. Or if he has undergone a pituitary surgery in the past, then you definitely have to think of a pituitary cause or a central or secondary hypothyroidism. Here the TSH is low, FT4 is low. Okay. Always rule out drugs because many a times there can be interference with drugs. If that has been ruled out, go ahead and do a testing for all hormones, do an MRI brain, look for the cause for your central hypothyroidism. Okay, fine. So this is about your approach to thyroid hormones. How do you approach your thyroid function testing in hypothyroidism? Fine. Now let us go on to the treatment. So how do you treat for your hypothyroidism? You have to give replacement, right? What do you replace? You levothyroxine. You replace with levothyroxine, LT4. Okay, LT4 is given at a dose of 1.6 microgram per kg body weight. Remember the dose, it is weight based. It's not that we just start them on 50 microgram, 100 microgram. No, you start them on a weight based dose of 1.6 microgram per kg body weight. For adults, it is usually started at dose of 50 to 100 microgram per day. In the elderly, you start at a lower dose. Why? Because in the elderly, most of the time they are usually frail. Some of them can also have cardiovascular morbidity. Now your heart is used to functioning at a specific heart rate. If they are hypothyroid and suddenly you replace them with a higher dose, then the heart rate is going to increase, right? they have bradycardia because of hypothyroidism, suddenly the heart rate is increasing. Will a frail heart or a weak heart keep up with it? No. So you can precipitate heart failure because of increased risk of heart failure. Okay, increased risk of cardiovascular disease prevalence there, increased risk of precipitating heart failure. In the elderly, you start at a lower dose. So you start low and you go slow. You increase at a slower dose as well. Now this levothyroxine basically has a T-half of up to 7 days. So in case a patient has missed the dose, then you ask them to take the 2 doses the next day. You take 2 doses the next day. Fine. So what are the interactions of levothyroxine? Levothyroxine has to be taken in the morning on an empty stomach because it has a lot of interactions with PPI, calcium, sucralfate, rifampicin, carbamazepine and phenytoin. Okay. So this is about how you will treat for your hypothyroidism. Now once you have started your treatment, when do you want to monitor? So you will monitor the TSH levels. The main goal is you have to bring back the TSH to within normal limits. So how do you monitor? You monitor the TSH levels after about 6 to 8 weeks. After about 6 to 8 weeks of initiation of treatment, and you counsel the patient that even after initiating, it will take about 4 weeks for symptomatic improvement. Okay. So every 6 to 8 weeks you monitor, you adjust the dose, you increase by 12.5 or 25 and so on and so forth until the TSH comes within the normal range. Once the patient is on a stable dose, then you can monitor it yearly. Then you monitor only yearly TSH once the patient has been on a stable dose. Now, subclinical hypothyroidism, when do you want to treat? So, subclinical hypothyroidism you treat when the TSH levels are more than 10. TSH levels are more than 10. Then, in pregnancy or in patients who are wanting to conceive, then your target TSH is less than 2.5, right? So, in such cases, even if it is a subclinical hypothyroidism, you have to treat the patient. Then, in patients with anti-TPO positivity, irrespective of what the TSH levels are, you have to treat. Okay? So, this is about your management of hypothyroidism. Now, let us look at the last portion of your hypothyroid disorders, which is your myxedema coma. Okay, so what is this myxedema coma? So, myxedema basically refers to the edema, which is a non-pitting edema, which is seen associated with hypothyroidism. Okay, so this myxedema coma is basically a condition where you have altered sensorium, you have decreased sensorium. In a patient with hypothyroidism, where there is severe hypothyroidism, you can have altered sensorium, you can have seizures, and patient can also go into coma. This is what we call as myxedema coma. So what are the precipitating factors? Often the precipitating factors are sepsis, okay, exposure to cold, or use of CNS depressants, So all of these are the precipitating factors which can result in myxedema. So the patient presents to you. So in a severe hypothyroid patient, when the patient presents to you with altered sensorium, seizures, coma, this is what we call as myxedema. Okay. Apart from this, what are the other clinical features? The other clinical features is that they can have recurrent episodes of hypoglycemia. They can have severe hypothermia, right? They can have a low blood pressure because hypothyroidism in itself can cause adrenal insufficiency. Patients with hypothyroidism have a poor adrenal reserve. So, whenever you have myxedema coma, there is a high chance of adrenal collapse. Okay, they can have a shock because of your adrenal insufficiency. Okay, so they can have recurrent hypoglycemia, hypothermia, low BP, altered sensorium. Fine. So, what is the treatment? First of all, you have to identify Myxedema coma, right? So this is identified because it is a diagnosis of exclusion. You have to ensure that there is no infection, there is nothing else happening in the brain or any reason for the altered sensorium. Okay, fine. So treatment is with LT4. You give it IV at 200 to 400 mg as the initial dose, and then you look for the response and continue it. Fine. So you give levothyroxine therapy. When do you give LT3? When do you give LT3? So once the LT4 is given, following that you can give levothyroxine at a dose of 5 to 20 microgram loading dose and continue it at 2.5 to 10 microgram 8th hourly. Okay, and you have to give a lot of supportive therapy, give them IV fluids, and you monitor the sugar. You monitor the sugar because they are prone to hypoglycemia. So you have to monitor the sugars. Then you will have to do rewarming strategies. You provide them with spacer blankets. Spacer blankets basically help in keeping the patient warm. You give warmed IV fluids, right? You pre-warm the IV fluids and give them. Okay, and then you will have to correct the underlying problem, which is your hypothyroidism. And what is the role of hydrocortisone? It is given as 200 mg IV stat and 100 mg followed by 100 mg maybe 8th hourly. Why? Because all these patients have an impaired adrenal reserve, and it is very, very important that you treat for your adrenal insufficiency as well. That is why you give your hydrocortisone. Okay, so this is about your Myxedema coma. So with this, we have come to the end of our chapter on hypothyroidism. So what all have we learned? We have learned about the etiologies. We have understood congenital hypothyroidism. We have understood Hashimoto's thyroiditis. We have understood about Myxedema coma. In the next session, we will be talking about hyperthyroidism. Thank you.